So,
So,
sir, your opening
shall I?
remarks.
Yes,
Yeah, Dr. Advait.
yes, sir. Yes. Good evening, everyone. Namaskar. And it is my profound privilege to welcome all of you for this second webinar of the series. Today, we have two eminent speakers from AIMS New Delhi who will be enlightening us on a relatively unexplored uh, part for pediatric surgeons. And at the outset, I would like Manoj Joshi sir, our chairman for SPTS, for his opening remark.
Thank you, Dr. Advait. Warm greetings and welcome you all to this second webinar of our Gyanyog series, what we have named it. Season first. This is the first season of the Gyanyog webinar. So this topic have been intriguing all of us, including our Honorable Secretary of the IAPS is very fond of cardiac surgeries. So we have tried keeping it here in our academic perspective. If we all remember, I mean, historical facts are there. Most of us are aware of it. When Robert Gross, I think, he first attempted or did successfully the PDA ligation after he took over from Dr. William Ladd. Since then, I mean, pediatric surgeons, not much because of the training period part of have not picked up all these congenital cardiac diseases. So we thought of like, if we are not doing, we should learn from our collaborative fraternities, share with them our knowledge and share with them our whatever issues we have while managing congenital anomalies, be it the indications for surgery or be it the timings for surgery or the other things, the questions which comes to the young surgeon's mind while they are managing the core pediatric surgical cases. So the aim of the society is the collaborative learning. So part of that, we will try to learn from both these honorable speakers today, and hopefully by the end of this session, we will become more wiser regarding this issue which we face. So let's begin the learning process. Thank you very much. Over to you, Advait.
Thank you, sir. The moderators for today's webinar are two very dynamic pediatric surgeons. Our first moderator is Dr. Vikesh Agrawal, who is professor and head of pediatric surgery at NSCB Medical College, Jabalpur, and he's currently honorary secretary of IAPS. Actually, for pediatric surgery fraternity, he doesn't need any introduction. He has been serving the association as honorary secretary for PACE and SPU previously. There's more than 100 publications to his credit and several book chapters. So, welcome you on board, sir. Looking forward to your support. And another moderator is Dr. Anjan Dua. He's a professor of pediatric surgery at All India Institute Medical College of Medical Sciences at New Delhi. He also has more than 200 publications to his credit, and he has special interest in pediatric minimal access and HPB surgery, and he's very much interested in recent advances like 3D modeling and digital image dynamics and all. And he is one of the key factors for arranging, key person who has arranged this webinar, and I thank you for that, Anjan. And welcome
Hook
you.
step. That's called the hook step when they describe,
Yes,
a particular dance.
Yes, hooks. Yeah, so so you are the person who's doing the hook step, who's doing the hook step. Welcome you as moderator. Over to you, both of you, Mr. and Anjan.
Advait,
Thank you.
I will accept Dr. Sumitra Biswas has logged in. If we can request him for his
Yes,
initial
sir. Yes, sir. It would be a pleasure, sir. Sir, I request Biswas, sir, our president of IAPS, to bless us with few remarks. His remarks.
I'm very much honored to join this webinar because as a specialist in Bengali, it is called Bishesh Oggo. That is Bishesh Oggo. That is specially handicapped. We know our subject. We do not know the basics of other subject which is not in our domain. This is a very good endeavor because thoracic surgery without cardiac things is adhura hota hai. I think it is incomplete. So it is a very good endeavor, and I am looking forward to hear from the our eminent speakers from All India Institute. And I welcome them all. Very good evening to all of you. Thank you.
Thank you, sir, for your blessing. Over to you, Vijay sir and Dr. Anjan.
Anjan, please take.
Thank you, Dr. Vikesh. Thank you, Dr. Advait. Good evening, Dr. Sumitra sir. So with that, without much ado, I'll straight away introduce our first speaker. He is Professor Saurav Kumar Gupta, Professor of Cardiology, and who has multiple publications to his credit, more than 150 to be precise. He has special interest in congenital heart disease, specifically morphoanatomy, advanced 3D visualization techniques, and cardiac hemodynamics. So with that introduction, Dr. Saurabh, you are ready for your presentation?
Yeah.
He will take us through his. He will guide us about, showcase the areas which we as pediatric surgeons must be aware about when we manage our tender patients, those with congenital anomalies who more often than not have associated cardiac problems as well. So over to you, Dr. Saurabh.
Yeah, thank you, Dr. Anjan, and thank you everyone else in the society for thinking through such a good kind of interactive session where we interact from different specialties, and I think that is the need of the hour. In current times, we are getting away from each other, which may be good in terms of developing expertise, but may not be great in terms of managing our patients in totality. So when I was given this task, I was a little unsure how to take it forward since I don't know exactly how much the pediatric surgery community is aware about this. So I have kind of balanced it a bit. It may not be the perfect as your requirement, but I hope that it is still lay the background to what we are looking for. So I'll try to give the overview of congenital heart disease. And so this was in 1926 in a textbook of pediatrics, which had only 5 pages on congenital heart disease. And it said that diagnosis is of not much importance because nothing much can be done. And that was a state of affairs almost 100 years back. And this was the first time when there was a systematic analysis by Maud Abbott in 1936, where she described more than 400 cardiac cases with congenital heart disease. And this was the first systematic analysis. First kind of big breakthrough in terms of management came in 1944, when Blalock, Taussig, and Thomas, they performed first surgery in 1944. And that kind of started the era of where we could think that, okay, congenital heart disease can be treated and managed well. So a lot has changed over the years. CSD is no longer untreatable. If treated well, CSD patients can live a near normal life. Repaired CSD patients have outnumbered unrepaired CSD world over. And the changing scenario also brings in a lot of challenge because it requires a lot of multidisciplinary management in these patients. Now, this understanding of CSD is important as and when we are treating our patients, because this is one of the most common causes of death among structural blood defects. It approximately, it affects approximately 1 in 100 live births, and 25% of CSDs are critical CSDs, which means that they mandate management within first year of life. In India, the scenario, despite a lot of development and progress, it's, I would say, quite dismal. As you can see over here, only 3% patients are operated in time. And there is a lot of regional variation in terms of how it is played out. As you can see, South is very well placed, while Northeast has no center where you can have a congenital cardiac surgery. Now, when it comes to heart, it says that form follows function, which means that if you have an architect, you will make the room depending upon its function. So here in congenital heart disease, physiology will follow the anatomy. So if there are anatomical abnormalities, that will lead to physiological abnormalities. Now we go back to the developmental basis of human heart. As we know, human heart is a four-chambered system where the right system and the left systems are completely separated for the needs of human beings, more active lifestyle, and that leads to full oxygenation, unlike in other amphibians where it is three-chambered and there is some form of mixing. And I would tell what is the importance of this understanding later on. Now, this cardiac development is intricate. As you can see that this is happening around 2 to 3 weeks. It starts happening after 2 to 3 weeks of, the gestation starts, and it's too early. Many times mothers may not be even knowing that there is a baby growing in their womb by the time heart is getting formed there. And it's very complex thing which happens. And as you can see over here, multiple structures develop and then resolve to make a complex structure of cardiovascular system. And there are multiple building blocks which are formed, which are used to make the cardiovascular system. And any of these things can go wrong, including the genetic factors that can make things very difficult. And that is the cause why this congenital heart disease has a very, very wide spectrum, and almost anything can happen when it comes to congenital heart disease. Now, this is the normal heart. As I was saying, when it is complete separation, the systemic venous blood goes to the lungs, oxygenates, and then comes back to the left side of the body to reach to the aorta, and there is full oxygenation, and we are using the lungs to its full potential. Now, when it comes to congenital heart diseases, it can be broadly classified into acyanotic or cyanotic. In acyanotic also, there can be two types. One is shunt lesion, where we typically mean that it is left to right shunt, which means that the left-sided circulation is giving some blood to the right-sided circulation. And the typical examples are ASD, VSD, PDA, outer pulmonary window, and PAPVC, means partial anomalous pulmonary venous connection. Other type of acyanotic lesions are obstructive lesions, where it can be obstruction at the level of LV inflow, where it can be mitral stenosis, LV outflow, when it can be aortic stenosis, coarctation of aorta, or there can be interruption of aortic arch. When there is obstruction to RV outflow, it can be pulmonary stenosis. In the cyanotic group, it can be because of bad connections, reversed connections, missing connections, and absent septation. So these are the four broad groups. And if we dwell into further, these are the five terrible T's of cyanotic congenital heart disease. Among these, bad connections are tetralogy of Fallot and truncus arteriosus. Reverse connection, if it is at the venous end, then it is total anomalous pulmonary venous connection. And at the arterial end, it would be transposition of great arteries. Missing connections, tricuspid atresia. One of the valve is missing, either tricuspid, pulmonary, mitral, or aortic. Whatever is happening is leading to a complex situation where there is intermixing of blood from right side to the left side as the cause of cyanosis. So these are five terrible T's. And among those, if there is a missing connection like tricuspid atresia or absent septation, or sometimes the formation of the heart is in such a manner that you cannot recreate a four-chambered heart, then we call them as functionally univentricular heart. And this is a very specific subset of congenital heart diseases, which has only palliation which is feasible, where we cannot cure these patients, and I'll be talking about a bit later. Now, all these congenital heart diseases can also be divided into 3-4 groups depending upon their clinical presentation. One would be hypotension or shock, heart failure or failure to thrive. Third group would be cyanosis or arterial desaturation, and fourth can be asymptomatic, where there can be either there may be a murmur or sometimes there may not be a murmur, and there are other findings on auscultation that can lead to identification of these diseases. Now, this is the hemodynamic classification of congenital heart disease. You can broadly tell that if there is shock or hypotension, we are dealing with some of the critical heart diseases where it is critical aortic stenosis, that the patient is not able to maintain the cardiac output. Other group is cyanosis or arterial desaturation, and heart failure. We know all that it may be because of increased pulmonary blood flow, as in cases of left to right shunt like VSD. Sometimes it may be because of pulmonary venous hypertension, where it is because of obstructed TAPVC. And we'll talk about this arterial desaturation, so I'm not going in detail here. Now, we have seen the normal circulation. Here you see that there can be a shunt between left and right. So what happens? The lungs allow higher flow to occur because lungs are low pressure system. So what happens is the pulmonary blood flow goes on increasing. It is more than the systemic blood flow. So we typically call these conditions as congenital heart diseases with increased pulmonary blood flow. And since the shunting is happening from left to right, there is no cyanosis in these patients. This can happen at the level of atrium when it can be pre-tricuspid, means before tricuspid valve, or it can be after the tricuspid valve when we call them as post-tricuspid. The prototype lesions here is, this is the ASD and this is the VSD. Now, as you can see over here in the ASD, the flow is happening during at low pressures during diastole mode. So they are less symptomatic and the symptoms are late onset. And the chamber which is more affected is the right atrium and the right ventricle. On the other hand, when it is post-tricuspid, like in VSD, the shunt is happening from LV to RV, and there is systolic transmission of pressure. So these patients have higher PA pressure, so they have high likelihood of PA.
I think we have lost his connection.
Something happened.
It was for a brief moment we lost you. Now you are back. Yeah.
Okay.
So we can
So
see you, we can hear you.
okay, fine. I'm sorry for that interruption. Okay, so here I was saying that post-tricuspid shunts have higher PA pressure, they have more hemodynamic effects, and therefore they have early onset symptoms, and symptoms are also more severe. So the prototype lesions are VSD, atrioventricular septal defect, aortopulmonary window, and patent ductus arteriosus. Now, this is how we clinically differentiate between whether it is pre-tricuspid or post-tricuspid. The majority of it is primarily for cardiologists, but suffice it to say that we have to remember which chamber is enlarged, because this is what is going to come in the echo report. If the echo report says that the right-sided chamber are enlarged, then we are talking about pre-tricuspid. If it is the left-sided chambers, then we are talking about post-tricuspid shunt lesions. Now here, one thing to remember is the defect is congenital, but the shunt is not. So what does it mean? The defect is there, but it will not start flowing unless the pulmonary vascular resistance has fallen, because the pulmonary vascular resistance at birth is very high. It gradually comes down. And only when it comes down significantly compared to the systemic resistance that the shunt establishes. And that happens around 1 to 1.5 months of age. And that is why patients, despite having a large VSD, may not be symptomatic in their first month of life, unless the patient is a preterm, low birth weight, or there are other issues in the patient. Now, this is the ASD. I'm sure you all know it. Just for clarification, this is the secondum type of ASD. This is sinus venosus type of ASD, and this is primum type of ASD. This is most common. This is the least common. And usually, since the symptoms are less, they may be operated or closed at 4 to 5 years of age, unless they are very symptomatic earlier on. Now, primum ASD and sinus venosus defects need surgical repair, but secondum ASD in most scenarios can be closed in the cath lab using a percutaneous device. As you can see over here, this device can be placed either under GA or without GA. And usually, if everything else is okay, we may do this procedure within, say, 30-40 minutes. Now, this is the ventricular septal defect. As you can see over here, ventricular septal defect is named based on where it lies in the septum. This is the most common subpulmonic or membranous, subaortic or membranous VSD. This is the inlet VSD. These are muscular VSDs, and this is a subpulmonic VSD. Why it is important to know this is because they have different natural history. The muscular VSD have high chances of spontaneous closure, and this is how we pick on echo. So echo is one-stop shop for all the cardiac diseases, and it's almost always possible to define the extent as well as the physiological aberrations of the disease. Now, VSD, not all VSDs need surgical closure or interventional closure. 25 to 30% VSDs may close, and of those, 60% may close by 3 years, and 90% closes by 8 years. And it is more likely in small VSDs, muscular and perimembranous VSDs. But that may not be true in large VSDs. Now, in large VSDs, as I was saying, this is the normal fall in PVR. So normally by 6 to 8 weeks, the pulmonary vascular resistance falls to normal level, and that allows shunting to happen. But if there is a VSD, then what happens? The pulmonary vascular resistance does not fall to the normal levels. rather it starts increasing later on. And if the patient is not treated in time, which is less than 1 year or maybe 2 years of age, then it may keep on increasing. And we call this condition as Eisenmenger syndrome, which is the most dreaded complication of VSD and should be avoided at whatever cost. So that is the importance of timely detection and management of these cases. So a small VSD may not need treatment and we may need to just keep on medical follow-up, while a moderate VSD, where the patient is symptomatic, may need treatment. And usually, since they are doing reasonably okay, we kind of treat them at around 1 to 2 years of age so that the risk is of surgery or interventional closure is not as much. Now, primarily VSD is closed surgically. However, in select cases, it may be closed with the device, as in this example. When it is large VSD, then these patients should be treated early. Timing of surgery, if the patient is symptomatic, it should be at diagnosis. If the symptoms are controlled, we may wait for 6 months of age. Actually, there is no minimal weight criteria, and unsupervised wait and watch is risky and should not be done. Beyond infancy, as I have already emphasized, there is risk of elevated pulmonary vascular resistance. So these patients need to be evaluated very carefully before we can PST. Now, PDA is the another post-tricuspid lesion. As the name suggests, this is the ductus arteriosus, which is patent, and it shuns from aorta to PA, and it also leads to left ventricular volume overload. And this is the echocardiography. Here, as you can see, the flow is happening from aorta to the pulmonary artery. Now, all PDAs needs closure unless they are silent and picked on only on echo. So a PDA which is picked on echo, but there is no murmur, does not need treatment, which means tiny PDA does not need treatment. Or if it has gone to Eisenmenger, also there is harm in closing, so we should not be closing. In most patients in today's era, device closure is the first choice. Surgical closure, surgical ligation is needed only if it is a large or tubular PDA. Morphology is not suitable for device closure, and preterm with very low birth weight, and that also is with riders, and I'll let you know how. Now, this is the timing. So large PDA to be treated as soon as possible. Moderate PDA, we may wait and do it by 6 months of age. Small PDAs, we can take time and treat them by 12 to 18 months of age. Now, this is a simple procedure of PDA device closure. Usually, if everything goes well, it takes around 15 to 20 minutes in cath lab. And this is kind of standard of care now. More than 95% PDAs can be treated with device closure. Now, with the advances in technique, with the availability of these small devices, which is kind of 1/5 or maybe 1/8 of this coin, this PDA can be closed even in preterm babies as low as 900 grammer. We also have done the similar at AIMS in like 10-12 cases. And I think this is quite a good advancement that these patients can be treated without surgical management. Now, that was about acyanotic congenital heart disease. I did not discuss about obstructive because of shortage of time. Now I'll focus on those conditions where there is arterial desaturation. So this is a tetralogy of Fallot, which is the prototype of cyanotic congenital heart disease. There is a large VSD and there is obstruction below the pulmonary valve. So this is a combination of VSD with pulmonary stenosis. And because of that, what happens is that there is shunting of this right-sided blood, which goes to the left side. And since there is deoxygenated blood going to the body, there is reduction in saturation. And that is what we are picking as either arterial desaturation or as cyanosis. Now, another group of conditions where there can be cyanosis is admixture lesions. So as the name suggests, if the mixing of systemic venous blood and the pulmonary venous blood, this is called as admixture lesion. And here, depending upon whether lungs are allowing more blood or less blood, they can have increased pulmonary blood flow or decreased pulmonary blood flow. And the examples are total anomalous pulmonary venous connection, where the pulmonary veins are connecting to SVC or right atrium, and therefore, there is mixing of venous blood of both sides, and that leads to admixture at atrial level. It can be tricuspid atresia, where the tricuspid valve is not formed, right ventricle is hypoplastic, so whole of the blood is mixing at left atrium from RA to LA, and therefore there is admixture. Sometimes there is no ventricular septum, and it becomes a single ventricle. It can also be that both the great arteries are arising commonly when it is called as common arterial trunk or truncus arteriosus. Again, as you can see over here, both the blood, the red and the blue, right and the left, both are mixing at this point, and there is complete admixture. So there is decreased pulmonary blood flow situation where there is stop. Second is admixture. And third, the most severe form of cyanosis is the transposition of great arteries, where there is switching of aorta and the pulmonary artery. Right ventricle is connected to the aorta. So there is 100% right to left shunt unless there is intermixing between at the level of ASD or VSD. So this is transposition of great arteries. As you can see, all of the RA, RV blood, which is deoxygenated, goes to aorta, and the left-sided blood is recirculating into pulmonary artery without contributing to oxygenation. Now, for congenital heart disease, age is not just a number. Age determines what are the possible causes. So depending upon when is the onset of cyanosis, we can differentiate what are the possible causes. Age also determines what are the likely conditions when we see these patients later. As you can see over here, TGA, 1 year survival is only 20% if they are not treated. On the other hand, if the patient of TOF is not treated, 70% of them are going to be there. So if the patient is coming after 1 year, TOF becomes much, much more likely than TGA. And although there are reports of very long survival, but practically speaking, most of the cyanotic congenital heart diseases are critical and they need to be treated in time. I think I'll be taking 3-4 minutes more. I hope that is okay. Anjan, that's fine.
Yeah, please go ahead. No problem.
Okay. So one
Yes,
more
sir.
concept I want to bring in here is that arterial desaturation is not same as cyanosis. Although cyanosis term is very often used, but arterial desaturation, as we know, is much more sensitive. And it is safe to say that all patients of cyanosis have arterial desaturation, but all patients with arterial desaturation do not have cyanosis because there can be milder form of arterial desaturation. So it is mandatory that we do pulse oximetry in right arm and one of the legs. If possible, if it's an older child, then at rest and following exertion, because then only we can pick this arterial desaturation, which may not be picked by simple visual analysis, especially if you are not experienced in that. So if you are suspecting congenital heart disease, you have to do a comprehensive clinical evaluation. Important thing I want to emphasize in the cardiovascular system, that it is the turbulence that produces murmur. If there is no gradient, there is no murmur. If there is high gradient, there is harsh murmur. So in a neonate, RV pressure is usually equal to LV pressure. So despite having a VSD, there may not be a murmur. Serious conditions may not have murmur, including TGA. So murmur is not a good sign to look for if you are suspecting CSD. There are better ways to do it. As you can see over here, a large VSD may not have a murmur. On the other hand, a small VSD may have a murmur. This is just to emphasize that murmur is not something which can rule out or rule in the possibility of congenital heart disease in a child. Now, reduced QP and increased QP is a concept because that leads us to tell that what are the possible causes or what are the possible underlying congenital heart diseases. And if the patient is having features of heart failure, which means suck rest suck cycle, interrupted feeding, failure to thrive, think of increased pulmonary blood flow situation that can be left to right shunt, or cyanotic congenital heart diseases with transposition physiology or admixture physiology. On the other hand, if the patient has a cyanosis as a main symptom, but there is nothing else, then it is likely to be TOF and not other conditions. X-ray is a very good modality to differentiate between these two groups. If there is cardiacally, you check whether there is pulmonary blood flow, which is more like in this condition or in this condition, or it is reduced as in this condition. So if there is increased pulmonary blood flow, so as I have been emphasizing, then it can be TGA physiology, as in this case, where it is typical said as agon-side appearance. If it is cardiomegaly with reduced pulmonary blood flow, it may indicate Epstein anomaly. Although these are finer things, but I'm sure that I'm giving this concept that with cardiomegaly, increased pulmonary blood flow or decreased pulmonary blood flow is able to differentiate between what kind of conditions we are dealing with. If there is no cardiomegaly, again, we have to see whether there is pulmonary venous hypertension as in obstructed TAPVC. And it is important to pick because This is sometimes misdiagnosed as hyaline membrane disease and treatment is delayed. And this is one of the possibilities when you see such an X-ray. So this is how you investigate an X-ray. You look at various things and then you come up with what is a possible differential. Now, congenital heart disease assessment in neonatal period is not that easy because congenital heart disease evolve over time. Approximately 1% of normal neonate may have a murmur. However, since congenital heart disease may have a serious connotation, all murmurs needs to be evaluated, and critical heart disease may not have a murmur that needs to be remembered in these patients. Now, this is the importance of why pulse oximetry should be done. As you can see, once pulse oximetry is added, the diagnostic gaps come down from 20% to almost 3 or 5%. And that is why all neonates should have pulse oximetry, as I have already emphasized. And this is the algorithm that needs to be followed whenever we are seeing these patients. So what to do if a neonate or an infant is having heart failure? Then depending upon whether it is a shunt lesion or obstructive lesion, we have to act. So if it is obstructive lesion and the patient is in shock or hypotension, then it is likely to be PDA dependent circulation. Then these patients require urgent evaluation by a pediatric cardiologist and starting of prostaglandin infusion, because that is only is going to stabilize the patient. If it is a shunt lesion, then it can be easily managed, then it can be electively managed. Similarly, if the patient has deep cyanosis, if the saturation is less than 80%, if the patient is having acidosis because of the patient is having respiratory distress, then there is no point in waiting. Either it is transposition physiology or it is trough physiology, which is having critically reduced pulmonary blood flow. Again, start prostaglandin and get pediatric cardiology evaluation. Prostaglandin is a great thing that has happened to all of us. Other palliative procedures are balloon atrial septostomy. That can be life-saving in a patient of TGA. And sometimes palliation needs to be done when the patient is not surgically fit. Like in this case, there can be right ventricular outflow tract stenting or PDA stenting. Now, this is the algorithm. If the surgery is not possible, then we can bail out these patients and buy some time for, while the patient is waiting for surgery. Now, this is how various CSDs are managed. This is the last slide of importance. As you can see, some of the conditions like critical AS, critical PS would need ABBD or PVBD in the neonatal period. Similarly, PDA stent for PDA dependent circulation, BAS for TGA, and neonatal surgeries for severe coag, TAPVC, and TGA needs to be done. Long-term status. Few congenital heart diseases like ASD, VSD, PDA, and PVBD, if they are treated in time, they are cured for life. There is no need for long-term follow-up also, but for others, long-term follow-up is needed, and some of the conditions can only be palliated, like bidirectional Glenn or Fontan for single ventricle. I'm sure Pradeep will be following that. So this is the summary. Congenital heart disease has a wide spectrum. CSD type determines the clinical presentation and management. Timely detection and management is crucial for optimal outcome. And with optimal care, a large majority can live a normal, near normal life. Long follow-up is mandatory. Thank you so much for patient hearing.
Thank you, Dr. Saurav. One thing I would like to say that it was when you presented, the knowledge gradient was so high that there was murmur going on all around for the last 20 to 25 minutes. But having said so, your presentation, the concepts were made so lucid. Even for a fraternity like us, I am sure everybody has gained a lot of knowledge from it. I'll take up if time permits. I'll take a few questions which were posted. One is about although it was not covered, what is IE prophylaxis, infective endocarditis prophylaxis? How important it is for our neonates or other that age group infancy where we do other interventions with a background congenital heart disease.
So what is said is that the bacteremia which is generated by most procedures is also generated by tooth brushing, which we do daily. So nowadays they say that IE prophylaxis as such is not recommended. What is required is to maintain a good dental hygiene unless they are high risk procedures. However, in Indian setup, since dental hygiene is always a doubtful thing, we keep on suggesting that they should follow a IE prophylaxis in our place. And one thing, since dental hygiene is very close to my heart, and I feel that that is a deficient area in on which we don't focus, every child beyond 1 year of age and every parent of such a child should be educated about need of dental hygiene, because that can save many patients from infective endocarditis, which can kill the patient even when heart disease is not killing them.
So it's a very important aspect brought out. One more question which was raised by Professor Manoj Joshi was about the parameters that you shall be using to decide when a child goes, when you go ahead with ASD or VSD closure before definitive surgery in a child who is having, you know, other anomalies like anorectal malformations that we deal with, as they may pose perioperative risks.
So, so if the patient is very symptomatic,
I mean, you should go ahead with ASD VSD closure before the definitive surgery for the
No.
congenital anomalies.
So
Yeah.
I think ASDs definitely can wait. So we
Okay.
don't close them by 4 or 5 years of age. We wait. VSD
Right.
also, if the patient is in gross heart failure, not gaining weight at all, having recurrent infection, then only we say that
That's a candidate. Yeah.
precedence. Otherwise, congenital anomalies which may require emergency surgery should take precedence in such a situation.
Right. Dr. Sunita Singh from Jaipur has asked whether do these device closures that you have shown in PDA and VSD, are these permanent or they need to be
Yes.
revised as a...
Yes, they are permanent. So once it is done successfully, there is no need of repeat device closure. Although we need to keep them on follow for a rare occurrence of complication later on, but for all practical purposes, they are done.
do we have time, Dr. Advait, before moving on to the next one, or we can take one more quick question?
Can I ask you a question? Yeah.
Sure, Dr. Vikesh, please go ahead.
So I was very patiently listening to your lecture, and I'm really impressed with the way you put up in front of pediatric surgeon. I understand it is really very challenging, but at the end of your talk, I have taken a few message for myself, and they were quite simple and easy to comprehend. And in fact, like murmur and all these desaturation, few new concepts you told us, probably we were not very aware about of all those things. My question to you, one thing which didn't got covered, we come across like antenatal counseling very often as a pediatric surgeon, because we are the primary referral point for antenatal detection after level 3 scan, level 2 scans. So what are the absolute indications for termination of pregnancy in antenatally diagnosed heart defects? And as I understand nowadays, sonologists, radiologists, they are like learning a lot how to do a fetal echo, and maybe you guys are also doing, and they keep taking opinion from pediatric cardiologists. So a lot of anomalies are diagnosed nowadays antenatally, and a lot of unnecessary terminations are also being done. That's why I'm raising this point. So could you please highlight what are the absolute indications for termination?
So I think I lost you in between, but I got your...
Okay. You are not audible.
Dr. Saurav, I think there's a glitch at your end. Maybe we can take it up once he rejoins.
Yeah.
Okay then. So, Dr. Advait, shall we move on to our next speaker?
Yeah, please go ahead.
Okay. So, so with that, Professor Gupta, who has already deep dived into this pediatric cardiac evaluation and how to strategize the management, will switch gears to the surgical perspectives. May I invite Dr. Pradeep Ramkrishna, who is a dear friend of mine. He has bailed us out a couple of times, both in elective OT and otherwise in emergency setup as well. He is Associate Professor, Cardiothoracic Vascular Surgery in AIIMS, New Delhi. It's a highly skilled pediatric cardiac surgeon whose focus areas include neonatal and infant heart surgeries, staged surgical strategies for complex congenital heart disease. And Dr. Saurav, so you have joined us back meanwhile. Not an issue. If you want to take that question, which I think is very important actually for all of us to know about. Yeah.
So So I think fetal echo has gone a lot of advancement. Almost everything can be diagnosed now. So my personal take would be very complex congenital heart diseases like hypoplastic left heart, complex single ventricles should be advised termination because despite palliation, they have a very, very bad outcome. But those conditions where surgical correction can be done, where there is requirement of 1 or 2 surgery and it is fine, I think we should tell them and counsel them accordingly.
Thank you.
Thank you, Dr. Saurav. Your presentation was definitely was an eye opener for all of us, and we
Yeah,
really
but I'm
learned a
sorry
lot.
to exceed. No,
No,
sorry
no,
to
that's
exceed
okay. I
time.
think
And then it's a
we
large
started a
topic.
bit
So,
late also. It's all right. You have covered it and made it
yeah.
quite crisp
Can
and
I ask a
simplified it.
quick question not related to
Sure, sure.
cardiology? You jumped your boxes of the hierarchy to the next slide. How do you do that? I mean, this is a technical
Uh,
question I'm asking regarding PowerPoint presentation you made. You jump your
uh,
hierarchy boxes to the next, merge with the next slide. How do you do that?
okay. So there is something called morph transition.
Okay.
In under the transition box, there is something called morph transition.
Oh, really?
You can set
Oh,
targets
yeah,
also where exactly
Now I'll
they will have.
explore.
yeah,
You
yeah,
can land them
yeah,
after the
yeah.
transition happens,
Thank
and
you.
multiple elements can be morphed and transitioned into the target.
I
So
learned another new thing today. Thank you.
very good. It's a high gradient, I said, Dr. Saurav. There's a potential difference, no? You know, potential difference of knowledge. Anyway, so let's move
I,
ahead.
yeah.
Yeah, please, Dr. Saurav.
No, I just want to say thank you. That's it. Yeah.
Right. So, going ahead with the introduction of Dr. Pradeep, yeah, like I said, he has a lot of collaboration with us with surgical units in coexisting anomalies. The most important one, if I remember correctly, was about on a patient having conjoined twin. If you remember, 2-3 years back we did it. So with that, his technical expertise and calm clinical judgment is what we remember. What we makes we attract, which highlights your persona. So with that, Dr. Pradeep, I would ask you to please take over and carry this webinar forward with the description of the surgical aspects of congenital heart disease.
Thank you, sir. Thanks for the kind kind introduction. At any time, I love to work with all the pediatric surgeons because you guys are so cool. It's good to have you to work with you on table. So now, I will like to somebody has asked a doubt how to proceed in a patient with congenital heart disease. Which one to do first, like non-cardiac heart or cardiac? So I am going to deal today more of practical points. Only some basic congenital heart disease I'll explain the surgical techniques, but my approach is going to be how it is going to be of importance for you for a pediatric thoracic surgeon. So having said that, let me start. Just it may, yeah. So, Saurabh sir has already given a brief idea of how the CHDs are classified. So, I'm not going to waste too much time here. So, first is acyanotic heart disease and cyanotic heart disease. They are the brief classification. In acyanotic heart disease, left to right shunts are the low risk lesions like atrial septal defect, ventricular septal defect, PD, and AVSDs, and obstructive lesions in the hello. The obstructive lesions.
Okay.
Yeah, the obstructive lesions. Second one is obstructive lesion, which is a very high risk. It's a high risk cardiac lesion for anybody, for a pediatric thoracic surgeon. If they come across these lesions, obstructive lesions like aortic stenosis or HOCM, and it's going to be a high risk. One should be clearly like have to be at vigilant. Next is cyanotic heart disease. Cyanosis per se is a high risk factor for a pediatric thoracic surgeon when they are going to operate for some other thing. Cyanosis is a high risk factor. And among this, the most common cyanotic heart disease which you're going to face is either tetralogy of Fallot or top physiology. And others will be like tricuspid atresia or univentricular physiology or admixture lesions like TAPVCs, truncus arteriosus. These are the common syndromes which will have the congenital heart disease like Downs, Turner's, and Downs is the most common which you're going to see, and other things like a Vactarell is going to be common, and Turner's are going to be common. and Williams. Atrial septal defect, first one, which is a very the least one need not bother unless it is very rarely they present with a heart failure or the pulmonary hypertension in the first second decade. They will be usually a quiescent lesion. So in the when the kid is in the first decade, and so it's the second most common CHD. It leads to left to right shunt at atrial level, which causes a diastolic shunting. Here there is only diastolic shunting, so the low pressure shunting. So it takes long time for it to generate high pressures or the high PA pressures, and thereby leading to pulmonary arterial hypertension. It won't happen in the first 3 decades. If it all happens, it happens. It's going to be late, and they are relatively safe lesion for a cardiac surgeon as well as for a non-cardiac pediatric surgeon. So here the spontaneous closure is rare unless if the defect is too small, and the types usually, as Sir has said, like the ostium secundum, sinus venosus, and primum defects, and coronary sinus defect. Various defects are there, out of which ostium secundum is a common one. And here you can see the surgical repair of the ostium secundum lesion. If you see, the patient is on cardiopulmonary bypass, and you can see the various cannulae, venous cannulae, the superior vena cava cannulae, and the inferior vena cava cannulae. And this is the right atrium. And after the right atrium is open, you can see a large defect here. It is the ostium secundum defect, where the ASD is closed with a patch closure. And when to close a ASD, if the ASD is like a is not causing any trouble, but still it is going to be a matter of concern for the parent. So usually before school going age, at the age of 4 to 5, the ASDs are usually repaired. Next, the most common congenital heart disease is the ventricular septal defect. If we exclude bicuspid aortic valve, as in many cases, most of the time they are asymptomatic and they don't cause any hemodynamic significant lesion. So here in the ventricular septal defect, unlike atrial septal defect, it's a post-tricuspid lesion. So it's a high pressure. Here there is both pressure and volume overload is going to happen. So these patients, they have portal hypertension. They develop pulmonary hypertension very early and compared to the ASD. So these are like bit high risk, and one should intervene as early as possible. And when these patients end up for any other coexistent or comorbidities or other surgeries, which pediatric thoracic surgeon has to do, or any pediatric general surgeon has to do, they have to be aware of one thing: whether the patient is having pulmonary hypertension or not. Because the pulmonary hypertension is again a big risk factor for patient to undergo any other surgeries, because these patients are prone for failure, cardiac failure, and pulmonary hypertensive crisis. So the most common types of lesions are perimembranous or inlet or the muscular or outlet VSDs based on the location of the septum. Again, if these VSDs can be small, moderate, or large. If it is small, nothing, and it won't cause much trouble. And moderate and large are really a matter of concern. So what if we don't close the VSDs? What is going to happen? Either it may have a spontaneous closure if it is a small lesion, or if it is a muscular VSDs, there is chance of closure till 1 year of age. And if we don't close, if the VSD is large, it can lead to like a failure and can lead to premature death. Or if the large VSDs can eventually within like couple of years, it will lead to pulmonary vascular disease, and finally leading to irreversible pulmonary vascular disease, leading to what is called Eisenmengerization. Or if the VSD is small or moderate, it leads to aortic valve prolapse and aortic regurgitation in cases of subaortic VSDs. And the VSDs, as abnormal communication or septal defect, it leads to abnormal flow, high pressure flow. That can lead to bacterial endocarditis. Infective endocarditis is another complication. The smaller the VSD, the more the chance of infective endocarditis. And because the turbulence is going to be more in a small VSD. And it can lead to acute pulmonary stenosis as well. Here you can see it's a schematic diagram where there is a normal heart connection where the vena cava is connected to right atrium, right ventricle, and pulmonary arteries. And from there, from lungs, the blood goes to pulmonary vein, and left atrium and left ventricle to aorta. Here it's a normal heart. But if you come here, you can see a ventricular septal defect, which leads to normal increased flow to the pulmonary artery. Thereby, the more blood comes back to the pulmonary vein and left atrium, and also to the ventricle, from where it is shunted again. So this leads to continuously increased pulmonary blood flow. So if you see over time, the left atrium, pulmonary artery, and left atrium and left ventricle are getting gradually increased in size, leading to cardiomegaly. So in X-ray, if you see the patient is having a cardiomegaly and in a VSD patient, going to have he may have the pulmonary hypertension. But if you see a patient where there is no cardiomegaly and there is only a right ventricular hypertrophy in a large VSD, it indicates the patient may have Eisenmengerization. It means the patient would have already, because in a VSD, it's the left ventricle. People may think that since the shunt is going to left to right, right ventricle may dilate, but it is right ventricle acts just like a conduit only. So it just shunts the blood from LV to pulmonary artery. So the right ventricle doesn't dilate first. It's the left ventricular volume overload scenario. So if you see a VSD with a cardiomegaly of left ventricular type of effects, the patient is not reached into the Eisenmengerization. If you see a right ventricular hypertrophy and no cardiomegaly, it means that the patient has had probably the Eisenmengerization. So those are high risk scenarios. One should properly detail evaluate. When to close the VSDs? VSDs, ideally, a small VSD you can keep in follow-up unless if there is any evidence of like a aortic valve prolapse leading to aortic regurgitation, then one have to intervene. And in case of moderate and large VSDs, one has to go if the patient is symptomatic as early as possible, or otherwise the closure is recommended in a moderate VSD at least by 2 to 5 years of age, or in large VSD, usually they will be symptomatic and they will have failure to thrive and they should be closed as early as possible. Then what is the method of closure? So device closure is well documented in case of muscular VSDs where all four rims are formed by septal muscle, ventricular muscle. But in case of subaortic VSDs or any VSD margin is formed by semilunar valves or it's a AV valve, then it is better to go for a surgical closure. Here one can see the images of surgical VSD closure. This is a post-anatomy. This is the head and and this is the assistant side and it's surgeon side. One can see the right atrium, right ventricle, aorta, and pulmonary artery. Here you can see the dilated pulmonary artery and the aorta is small here. Because of the post-tricuspid lesion, shunting, pulmonary artery is enlarged, but aorta will be small in here. So what we did is we put the patient on cardiopulmonary bypass, aortic cannula, and a vena cava cannula, and the cardioplegia is given and the heart is arrested. Right atrium is open. One can see where my sucker tip is there, where it is marked with a marker pen. This is the ventricular septal defect. Here you can see it's a subaortic VSD where I don't know whether you're able to appreciate this. The faint white structure is the aortic valve, and this is the tricuspid valve. So in these scenarios, it is best to go for a surgical patch closure repair. So again, we do all the surgeries with the cardiopulmonary bypass machine, and where it's basically the machine also called as heart-lung machine. For us to operate, we need to keep the heart immobile. Two basic criteria: heart should be immobile, and there should not be any blood in the field. So what we do is we divert all the blood to the heart-lung machine, take the blood from the vena cava using two venous cannulae. They are oxygenated by the membrane oxygenator. Here you can see the venous reservoir with integrated oxygenator. They get oxygenated, and with the pump here, the oxygenated blood is given back to the arterial cannula to the aorta. For you to better explain, the venous cannula is a schematic representation here. We take the venous blood and we take into the reservoir, and there lies a pump. And with the help of the pump acts like a heart, and it pushes the blood to the oxygenator, which acts like a lung. And then this blood is given directly to the aorta, so that the work of heart and lung is taken care of. But to immobilize the heart, what we do is we give cardioplegia. Here one can see the cardioplegia cannula here. So this will be the cardioplegia cannula. Here we put a clamp so that the systemic perfusion is taken care of. And this clamp will segregate the oxygenated blood from entering the heart. We put a clamp here and we give potassium-rich blood cardioplegia to immobilize the heart. That's how we make the heart immobilized, and we correct the do the surgical repair, after which the clamp is released. So the potassium-rich blood is washed off from the myocardium, and the heart will start beating. These are basic principles of cardiopulmonary using cardiopulmonary bypass for surgical repairs. Again, this is a PDA, patent ductus arteriosus. It is again it's abnormal patent communication between aorta to pulmonary artery. It constitutes around 5 to 10% of all CHDs. Again, here there is both systolic and diastolic shunting with both pressure and volume overload. Because in VSD there is systolic shunting and ASD is diastolic shunting. Here, since the pressure gradient between aorta and the pulmonary artery is there in both systole and diastole, there is continuous flow of blood with high pressure into the pulmonary artery. So this is the one which this scenario leads to very early pulmonary hypertension. So they request very immediate attention. Again, it can be small, moderate, or large, with Torop was already dealt with. Here you can see the hugely dilated pulmonary artery, which shows the patient is in PAH, and when to go for a PDA closure. Patient usually in a large PDA, one has to go for immediately to prevent pulmonary hypertension. And in a moderate PDA, you can go a bit late, but before definitely by 1 year. And small is PDAs, you can wait. And if it is really uh, uh, leading to pulmonary hypertension, then one can think of going for closure. Silent PDA, I don't think any, Sarah rightly said, there is no need of any intervention. Here also, first, if possible, first option is device closure. If not, then only we'll go for in a large PDA, window PDAs, then we may think of going for a surgical closure. Here you can see a picture where there's usually the PDA closure is done without the help of cardiopulmonary bypass. It's a closed heart procedure. We do a left thoracotomy, and left thoracotomy, one accesses the DTA, and one with that, on tracing the DTA, one will lead to arch dissection, and then the PDA will be just below the arch, and one can identify the PDA and ligate it. This is AVSD. Just here the atrioventricular septal defect. It's an endocardial cushion defect. It can be like a complete AVSD, which means there will be both a ostium primum ASD and there will be a VSD. But under partial AVSD, there will be only a ASD. There won't be any VSD. Most commonly encountered with Down syndrome. And here, both the atrial shunting and ventricular shunting happens together in the same patient, along with mitral valve anomaly, where usually a cleft mitral valve will be there, which can lead to mitral regurgitation. So this subset is very highly prone for pulmonary hypertension. So as soon as they are diagnosed, it's better to go for immediate repair. So if patient is unstable and high congestive heart failure, decongest them and go for immediate open surgical patch closure. Again, the obstructive lesion, which I thought I should discuss, is the coarctation aorta. You know that narrowing of aortic isthmus happens at the with or without arch hypoplasia. Here one can see the discrete coarctation. This is the first one, shows discrete coarctation, where there is only post distal to left subclavian, that's a discrete narrowing. And while compared with the tubular coarctation, well, there's a long segment coarctation with hypoplasia. So this usually can present in bimodal. One, if there is a when the PDA starts to close, if there is no adequate collaterals, and if the fetal circulation was carried by the large PDA, the moment it starts to close, the patient will, the lower body gets immediately becoming like ischemic, and they will present in the neonatal period. The other subset is they will present in the elderly age when there was adequate collaterals or the coarctation was not tight. Those patients, they won't present in the neonatal age. They will present later. Yes, any PDA with a gradient of more than 20, one should go for a surgical repair. The first option is surgical repair, and the intervention is indicated only when there is a residual coarctation or recurrent coarctation. Again, this one is a most common cyanotic congenital heart disease, which we encounter. As Sarah said, they won't present in the neonatal period because the obstruction it present after the 6 weeks, and it takes time. Even after the 3 months, they won't. Till then, they won't present with any symptoms. After that, the obstruction develops gradually. So the basic pathophysiology is like the anterocephalad deviation of the coronal septum, which is the ventricular septum, which gets deviated anteriorly. The septum comes more anteriorly and towards the right ventricular outflow tract. Here one can see the schematic representation picture. There is a septum gets deviated more anteriorly, leading to RVOT obstruction. As it gets deviated anteriorly, that creates a defect in the ventricular septal wall, which leads to a large VSD, and overriding. Along with that, pulls the aortic annulus anteriorly, which causes the override. And as secondary manifestation of the right ventricular outflow obstruction, the fourth feature, the right ventricular hypertrophy, happens. So putting simply, it's a large, usually we are traditionally taught with the four defects, four pathologies, the RVOT obstruction, VSD, overriding of aorta, and RV hypertrophy. The present concept is it's all the consequence of the one single anomaly, which is the anterocephalad deviation of the coronal septum. Why we are concerned about this is because they are prone to cause what something called cyanotic spells, episodes of acute cyanosis, which can be life-threatening. And sadly, the patients are prone for cyanotic spells during perioperative period. Any surgery, suppose a patient is going to go for a any anorectal malformation surgery, and the patient has not uncorrected tetralogy, the chance of any decrease in SVR, which means the systemic vascular resistance, which lead to the what happens is the aortic the afterload is going to be less. So the more right to left shunting is going to happen, and there will be more desaturation. So these patients are very high prone for cyanotic spells during the perioperative period, which pediatric surgeon should be aware of. So treatment in if it's a very small kid or a neonate or young infant, one can go for a BT shunt, dialoctosic shunt, where a shunt is put between the subclavian artery to the branch PA, pulmonary arteries. And if it's older children above 6 months, we go for total correction. Even the infant neonatal corrections are carried out, but in our institute we don't go for total correction, which means we close the VSD and we relieve the pulmonary obstruction, pulmonary stenosis. So here one thing which I think you should know is if the pulmonary annulus is very good sized, if it is only the muscular obstruction, the pulmonary stenosis can be due to infundibular, which means a muscular obstruction, or it can be due to a valvular obstruction. The pulmonary valve, let's say, may be stenotic, or the annulus may be small. In this, the isolated muscular obstruction have a good prognosis. Sorry, because they don't lead to like we have to resect only the muscle. We don't need to enlarge the annulus. If the annulus is small, then one have to go for a transannular patch. What is called, we basically cut the pulmonary annulus and we put a patch over. This makes the pulmonary valve regurgitant. If at all you see any post-op correction with transannular patch and a free PR, again that patient is a high risk patient for your surgical repair. So you have to be careful. Single ventricle physiology, this diagnosis per se is a very bad prognostic factor. Even for us, we also struggle. And for non-cardiac surgeries, single ventricle physiology is categorically a high risk subset. So it includes a spectrum of diseases. I don't want to go into this. You should tricuspid atresia and other unbalanced AVSDs, or it can be any non-routable VSDs with a DORV. It can basically it's a either the patient may have only single ventricle or two ventricle with non-correctable defect. These are widely grouped into the single ventricle physiology. What do we do for these patients? These patients, we do three-staged repair. First stage repair is the BT shunt, where innominate artery is connected to the pulmonary, or subclavian artery is connected to the pulmonary artery. One can see here. So this is the thing. So if it is an increased QP and decreased QP univentricular physiology. For decreased QP, which means decreased pulmonary blood flow, we go for a BT shunt. And if it is an increased pulmonary blood flow, then one has to go for a PA band, where we just constrict the pulmonary artery to create a pulmonary stenosis. Iatrogenic pulmonary stenosis we create so that the distal pulmonary tree is suitable and it doesn't go to high PA pressure, because flow is not restricted, then the PA pressure will increase, so that further correction will be impossible. So stage BT shunt or PA band. Second stage is bidirectional Glenn or a superior cavopulmonary anastomosis. So you can see the patient has only one single ventricle, so we have to protect this ventricle. So what we do is, if the patient reaches earlier 6 months of age, we disconnect the superior vena cava and attach it to the pulmonary artery. So how it helps? It's going to help the patient by giving a reliable source of blood flow to the pulmonary tree. So this then is going to ensure the oxygenation is going to be better. And also what happens is this superior vena cava and inferior vena cava blood goes to the ventricle. If we don't reroute it, it goes to the ventricle, and again it goes to the pulmonary artery, and again it will come back to the the ventricle, same common ventricle. So it leads to continuous over circulation of the same blood, which leads to eventually ventricular failure. So what we do is we shunt this blood and we disconnect it to and we are not allowing it to go through the same ventricle again and again. So ventricular dilatation and dysfunction is prevented. So BD Glenn is a better. Why I'm stressing on this area is, for a pediatric surgeon, if one has to operate among these three stages, I will suggest one should go for a pediatric other non-cardiac procedure after a BD Glenn is done. The stage 2, post stage 2 is the best window period for somebody to get their procedure, associated anomalies to be get corrected. And the final repair is the Fontaine operation or a total cavopulmonary anastomosis. Nothing but the inferior vena cava is also connected to the pulmonary artery, thereby bypassing the right ventricle. All the right-sided blood is bypassed from the systemic ventricle, and they are given to a passive direct pulmonary circulation, so that the ventricles are definitely like not exposed to volume overload. And this is the final repair in the univentricular physiology. This fontan, is it really a curative? No, it means not curative. Eventually, they may fail, and it can lead to may necessitate to go for further future heart or heart lung transplant. As I already said, due to lack of time, I'm not going in detail. The best time to operate in single ventricular physiology, if it is not an emergency procedure, then it's best after the stage 2 palliation. Is that at least if this much thing, if you're able to make it, then it is good. This another one important thing in a post-Fontan patients is the hydration is the most important thing, because there is no pumping chamber for the Fontan circuit, and they are just passive flow. It's the preload dependent circuit. So in any Fontan patients, the venous pressure has to be kept high by giving more IV fluids, even up to 20 ml per kg, to maintain the cardiac output. And vasoconstrictors may be required for perioperative management. I already said why it is important for a pediatric surgeon, because the approximately 30% of CHD children have associated extra cardiac anomalies, and among 40% of those who underwent congenital heart disease surgery get their other associated anomaly repaired by a pediatric surgeon under 5 years of age. The most common defects are those bacterial defects, Downs, abdominal wall, and diaphragmatic defects. And definitely the mortality and morbidity is going to be double the other non-cardiac patients. So who is a high risk? Those infants and those and even up to less than 2 years of age, they are at the high risk. Most common cardiac the complications are the cardiac arrest, reintubation is higher in these patients, infection and renal failure, neurological complications, and thromboembolic complications are higher in these patients. In older age groups, more than 2 years of age, it is shown that they don't significantly affect the morbidity and mortality, which means like the CHD is not going to greatly affect the morbidity and mortality. What is more important is an integrated team, which is the most important thing here. We need which the team includes pediatric cardiologist, and a pediatric cardiac surgeon, and a pediatric general surgeon, a cardiac anesthesiologist, a cardiac and general surgical nurse, and dietitian is also very important, because these CHD patients have very high BMR. So their nutrition has to be adequate in the perioperative period. And a physiotherapist is very important, and also a perfusionist with ECMO experience. Again, this tableau column which shows the high risk subsets for the CHD patients who are going to undergo non-cardiac surgeries, those less than 2 years of age, and complex lesion. As said, the first is the single ventricular physiology and cardiomyopathy and aortic stenosis, which is the left-sided obstructive lesions. They are again a high risk entity. The third one is any major surgery. What surgery you're going to do? Suppose if you compare a LATS procedure with circumcision, definitely circumcision is a low risk, and LATS procedure is going to be high risk. Major surgery. And any emergency surgery, suppose the patient is having a bowel ischemia, you have to go and operate immediately, then again it's a high risk procedure, despite irrespective of what the cardiac lesion is. And any presence of long-term sequelae like arrhythmia, cardiac failure, pulmonary hypertension, and cyanosis, all these four are like high risk entity. Any arrhythmias is definitely going to be cause a periop hemodynamic instability, especially if you see a patient with a atrial switch, which means which is done for a TGA. I'm not going into those detailed surgical things because too much beyond the scope of this time. For TGA atrial switch, if has been done, these patients are prone for atrial arrhythmia, tachyarrhythmias. So if you see in a discharge summary atrial switch, again, yes, this patient is going to high risk. And if any tetralogy, if you see a tetralogy with transannular patch, yes, they are also prone for ventricular arrhythmias. So, and any single ventricular physiology with any ventricular dysfunction, any ventricular dysfunction, again, it's going to predispose for arrhythmias. So if you see in a ECG any the frequent ventricular ectopics, it's an ominous sign. 30% chance of mortality in these patients in the perioperative period. Prolonged QT interval is a high risk. Cardiac failure, any ventricular dysfunction is going to cause a high risk. And pulmonary hypertension, which is defined as a mean PA pressure more than 20 millimeter of mercury at rest. And when the pulmonary hypertension is going to happen, any left to right shunt which has Eisenmengerized. it is going to cause, or even otherwise also not Eisenmenger, even otherwise the flow-related pulmonary hypertension is also a high-risk entity. And any left-sided obstructive lesions like obstructed TAPVCs or even left-sided subaortic stenosis or aortic stenosis or supravalvular aortic stenosis, all these are like left-sided obstructive lesions, or even admixture lesions like truncus arteriosus. They are prone for pulmonary hypertension. Why this pulmonary hypertension is a risk factor? Because what happens is they decreases the lung compliance and increases the airway resistance and increases the work of breathing. It happens because of micro changes which happens in the small pulmonary arteries, which is chronically exposed to very high pressure. The pulmonary pressure is very less. We know it is a mean of 15 around is a normal. If it is chronically exposed to systemic pressure, like for example in PDA, it damages the arterioles in such a way that it leads to intimal hyperplasia and complete obliteration of the arterioles. So that predisposes the patient to very high PA pressure. It can lead to something called in the perioperative period called pulmonary arterial hypertension crisis, PAH crisis, what we call. It's defined as the acute elevation of PA pressure above the mean systemic arterial pressure, mediated by abrupt elevations in the pulmonary vascular resistance, which leads to severe RV dysfunction, acute severe RV dysfunction, leading to systemic hypertension and low cardiac output. So these patients, during the perioperative period, those who are with pulmonary hypertension, you have to be careful. They require ICU care and they require very deep sedation and paralysis, and hypoxia, hypercarbia, and acidosis have to be treated. And pulmonary arterial vasodilators are very important in those patients, like sildenafil or phenoxybenzamine or any milrinone or NTGs. They are very important to support the RV function. Left-sided obstructive lesions, as I already told, they are a very high-risk entity because they can lead to sudden decrease in the forward flow. As there is a fixed obstruction, they cause subendocardial ischemia because of hypertrophy, ventricular dysfunction, and as the forward flow is reduced, coronary blood flow is compromised, and hypotension. These are the most common hemodynamic problems. And these patients, they are prone for instability during the induction period, the maximum, because during induction, for a case, the systemic vascular resistance or the afterload suddenly decreases because of the induction agent. For example, propofol is leads to sudden decrease in SVR. So in this patient, ketamines are preferred, so which doesn't decrease the SVR. So that leads to this is very important. The anesthetist who is well versed with these patients can manage them better. Otherwise, they are a high risk patient. Cardiomyopathies, yes, we all know it is a very high risk. Again, HOCM and dilated cardiomyopathy are the more common entities. Restricted cardiomyopathy are rare in the pediatric sector. I'm not going into detail. And this classification I want to show you because this is a classification by American College of Surgeons, who has made a risk stratification of CHD on those patients who are going to undergo non-cardiac surgeries. First one is a minor, where the cardiac condition with or without medication and maintenance, which means ASD or a small or not a very significant VSDs without any much symptom. They are classified into repair, or any corrected congenital heart disease without no much residual lesions. Like for example, a tetralogy of repair, which is repaired without any transannular patch, it will fall into the minor minor condition, minor CHD. And second one is a major CHD. Here, congenital heart disease with residual hemodynamic abnormality who is on or off medication. Here you can see the first one is a tetralogy with free pulmonary regurgitation or any hypoplastic HLHS, including stage 1 palliation. All they are major. What is a severe CHD? Uncorrected cyanotic congenital heart disease. Here again, a TOF can fall into this uncorrected tetralogy, or a patient with pulmonary hypertension or any ventricular dysfunction, or those patients who are very sick and listed for heart transplantation, they are also severe CHD. This flow chart gives a simplified idea how a pediatric surgeon should approach the CHD patients. Here you see if it's an emergency procedure in a known CHD patient, yes, you go for take consent of the team, discuss with them and go for surgery. No need to wait. If it is not an emergency procedure, risk assessment is important. See, assess what is the cardiac lesion. It can be stratified as the minor, major, or severe. And age less than 2 years, yes, you have to keep it as a high risk entity. Look for any other major comorbidities, and you see what is the non-cardiac procedure. Is it major or minor? Look at it. Now, see here, if it comes as a minor, if it's a minor, comes under the less minor CHD, one needn't worry much. One can go for a surgery directly. And if it is a severe CHD here on the other side of the spectrum, the severe CHD, it's a very high risk entity. So you have to contact integrated pediatric cardiologists and pediatric cardiac anesthesiologists, take their help and take the maximum help in such a way that the ICU bed and in OR, you have them and proceed for surgery if it is an emergency, or if it is not an emergency, get the cardiac lesion sorted out and then come for your non-cardiac procedure. And if it is a major CHD, again, you can risk stratify if it is an emergency or if it is a Glenn or Fontan circulation univentricle, or if the patient is on inotropic support, or if it is a pre-op CPR, or if there is patient is already on ventilator, or if the patient has renal problem, then they are again stratified as a high risk entity. Again, the same protocol for CHD will be followed for major CHD also. If they are not there, they are still considered as a low risk entity, and one can go for surgery, non-cardiac surgery immediately. So discuss those things. Now, timing of surgery. One thing which I wanted to say is like complexity of surgery, cardiac defect, and functional status is going to decide the outcome. More complex your surgery, it is going to be high risk, and cardiac lesion is there, major or severe CHD, again, it's going to be high risk. And how are we going to correct them? When to do what? Whenever possible, the non-cardiac surgery is better to be deferred before the cardiac lesion gets corrected, unless it is an emergency. If it is a low risk and emergency, then non-cardiac surgery can be done first. Otherwise, it's always a cardiac defect which should be dealt first. If possible for a single stage repair, yes, with the whole integrated team in the OR, one can go for that. So here one can see the pentology of Cantrell with the VSD. This case, I have collaborated with Dr. Anjan. We did in cardiac OT with the help of pediatric cardiac anesthetists and pediatric perfusionists and our pediatric cardiologists who have seen and cleared. It is an isolated VSD with the LV diverticulum and anterior abdominal wall and diaphragmatic defect. So we did it collaboratively, and we put the patient on cardiopulmonary bypass. We repaired the LV diverticulum and, by direct repair, and the VSD has been closed. I didn't get the VSD picture here. And following by which the anterior wall defect has also been, an omphalocele was there, which was closed by Professor Anjan. Here, we decided to collaborate and do it in a single go, because if if it had it been any other CHD, like if it is a single ventricle physiology, and probably I wouldn't have gone for a single stage repair. I will first correct the in a cardiac OT, I'll correct the LV diverticulum, and then I'll go for anterior wall defect repair, followed by which I would have gone for a two-stage second stage what to say, like a univentricle physiology surgery. The other one, since it's an isolated VSD, I thought I will go for a single repair. This is a Vactrel with a TOF patient. This was, I think, was operated. This is under pediatric surgeon, Dr. Sandeep Agarwala is looking after this patient. What we did with this patient had anorectal malformation. The patient was already operated with a stoma, and there was a feeding tube. He was waiting for the curative surgery from your side, but it's a tetralogy of fallow. So what we did was we first corrected the repair. So it's better to uncorrected tetralogy of fallow is a major CHD. We thought we will correct it first and then we'll send for it. So we corrected it, and the patient had a very bad post-operative course. He was on ECMO for a short duration, and then he recovered, and now he is waiting for the anorectal malformation surgery. Here, I don't know whether you are able to appreciate the echo, you can see the post-ICR plus TAP, transannular patch. This patient is going to be high risk for your anorectal malformation surgery because he's having a residual lesion, which means the pulmonary regurgitation. So this patient requires integrated care during the perioperative period. Almost the same thing which I have already described. So here we can.
I'm afraid, Dr. Pradeep.
Yeah, the time is we're running out of
yeah. Not an
so,
issue.
yeah.
You just.
Yeah. So like I'll skip a bit of the slides. The preoperative, the evaluation has to be very critical. One should look for any gross polycythemia or thrombocytopenia has to be corrected. The thrombocytopenia usually in cyanotic patients, they may not have any qualitative defect, but quantitative. Usually the thrombocytopenia is seen in CHDs, but they may or may not have qualitative dysfunction that has to be evaluated. These patients are more prone for bleeding during the non-cardiac surgeries. So, and if any patient has BT shunt, the cyanotic patients, one should be weigh the risk of shunt thrombosis versus bleeding. So it has to be discussed with the cardiac team. And if your bleeding risk is less, better to continue the aspirin. And pre-op evaluation, oxygenation, the lung infections has to be ruled out because they will have significant impact on pulmonary hypertension patients as well as in univentricular physiology. A recent echo is very important, and all arrhythmias has to be ruled out, and strategize the risk by echo or any recent imaging modality for you to be more confident on your perioperative course. Drug history, the main cause of instability in perioperative period is the hypovolemia, either due to bleeding or due to dehydration, or third one is the massive transfusion leading to hypokalemia. These are the main reasons for a perioperative arrest. So one should correct these things, like hypovolemia has to be corrected, and drugs like diuretics, one should ensure whether they are optimized or not. Endocarditis prophylaxis, from a surgeon's aspect, the patient has undergone a surgery, any prosthetic grafts or prosthetic patches, or if any prosthetic heart valves is there, it's better to have endocarditis prophylaxis. And high risk consent is mandatory in these patients. And most of the things are covered in the intraoperative concerns. If you're going for especially continuous intra-invasive monitoring is essential, and laparoscopy or thoracoscopic surgery is an additional stress for these patients. So one should be careful because of decreased venous return due to CO2 insufflation, and it leads to decreased cardiac output and increased airway pressure and hypercarbia. So laparoscopic and thoracoscopic procedures are a bit high risk for cardiac patients. Post-op care, it is like one should have a major and severe CHDs, one should have a ICU bed, and continuous invasive monitoring is essential, and vasoconstrictors or volume resuscitation has to be optimized. And as said, like anticoagulation, one should assess once as far early as the bleeding risk is over, especially in cases of Fontan, and all the anticoagulation is essential to avoid thrombotic complications. Thank you. It was a bit more extensive, but
No. I think I must congratulate you for covering the entire. It's a vast topic, and covering it in 20-25 minutes would be
I
definitely
didn't want
difficult.
to go
But
more
what?
into my surgical thing. I wanted to just say like what is more essential for you. So
Yes.
I thought in your aspect, and I said that.
So definitely, you have kind of stimulated and shown us a glimpse of how things are done in your OT with that CABG machine, the kind of orchestra-like arrangement of the coordination between you, the perfusionist, and the anesthetist, how it plays a major role. Now, before going further, let me take up few questions from the. Is Dr. Saurabh also still there with us, Dr. Advait?
I think
I'm
Okay,
here,
so I
Anjan.
think there are two.
Yeah.
Okay, so there are two questions. I think one Dr. Saurav can address. The first one you have partially touched upon is in syndromic babies like Bactral or Charge. How does the surgical approach in these patients differ, if at all? So I think you have partially shown us one case, the ARM child.
it's
Yeah,
basically yes.
Doctor.
But it depends on the asset. The same cardiac defect. What is the cardiac defect? If is it a minor defect, and if it is your surgery is emergency. Suppose if you are having any major bowel ischemia or any major surgeries, you can go for immediately. Or if the patient is having high atresia lesion, if you have to go for a stoma and a feeding thing, if it's a minor defect, minor cardiac defect, one can go for a procedure first, and then we can go for a correction. But if it is the
Right.
same thing, if it's high risk lesion like TOF, better if you do as minimum as possible, and then first let us correct the repair. This like this Bacterial repair, he has a TOF, tetralogy of fellow, uncorrected tetralogy of fellow is a major CHD. So we went for first the CHD, and then we went for your elective procedure. So for
Correct.
example, again,
So
same scenario, like if it's a single ventricle physiology, if you can wait. So these patients may single ventricle physiology, usually they have heterotaxy, which means they may have malrotation, and lat procedure may be needed. If it is not every emergency, let us first reach till the glen, and then you can go for your
and then
procedure.
do the second wait
Yeah.
in that interim
Rather
period.
than
So
to do
basically it's about whether decide emergency non-emergency versus the cardiac risk assessment, and depending on that we take up. So the next question before taking up the other one. Okay, let's take the other one and ask Dr. Saurabh about your thoughts about prognostication for congenital heart disease on antenatal scan. I think it has been taken up. Sorry. The conditions where one must recommend fetal echo when CHD is detected on antenatal scan. This was the
So
question.
yeah, So I think what we have to understand is that there is something called level 2 scan, which is done between 14 to 18 weeks, where we start suspecting whether there are serious malformations there or not. So in that level 2 scan,
Right.
there are limited views which are done for congenital heart disease. They are usually done to pick gross anomalies. So, and since those people who are doing level 2 scan may not be so conversant with the cardiac anatomy as much, so it is always a great idea to always confirm with the fetal echo. So if there is anomaly, it should be confirmed. Secondly, if there are anomalies which are commonly associated with complex congenital heart diseases, should again be subjected to fetal echo. Regarding prognostication, we have already discussed that a general trend of any congenital heart disease and termination may not be a great thing, which is probably happening in the society. But yes, having said that, there are conditions where the outcomes are quite dismal despite a lot of efforts. As of now, probably those are the conditions which may be, recommended termination. For example, hypoplastic left heart, complex CHD, complex single ventricle with atrioventricular septal defect, heterotaxy, and where the one of the ventricles is not formed well, I would say.
Right. Coming back to Dr. Pradeep, one aspect which I thought is important for us as pediatric surgeons to know is the role of, because you approach the heart by doing a median sternotomy, right? So consider a situation where we have done a TF case, a tracheoesophageal fistula case, who has also undergone gastric pull-up or basically esophageal replacement, and somebody chooses a retrosternal route for doing that. How difficult this situation is when you consider offering a surgery from your side if the child needs some kind of a surgery for a congenital heart disease?
It is
How
definitely
to
going to
address
be,
this kind of, yeah.
whenever possible, it is better to avoid the retrosternal pull-up, because it is definitely going to be a high risk for us. Because
So this is very important.
yeah, so while doing sternotomy, and even after that also, one has to go for like a pericardiotomy to access the heart. This pull-up is between the sternum and the pericardium. So definitely there is going to be a high risk of entry into the bowel. And second thing, if possible, you go for a posterior mediastinal, you go for a posterior
Yeah.
pull-up. If
So
at
that's
all
the
not,
transhiatal route, the orthotopic route
yeah,
that we
if
normally choose.
not
But then
possible,
there are, yeah.
if not possible, and the patient is going to be patient is having a CHD who may require a repair, it's going to be really a troublesome scenario. But if it is a simple repair, like minor CHDs like ASD, VSDs, and PDA, one has to go for one can otherwise also do by left thoracotomy and correct it. Or if it is ASD or PDA, nowadays there is something called minimally invasive cardiac surgery. So what basically is done, people go through the thoracotomy. So rather than doing a sternotomy, one can go for a right thoracotomy to correct these repairs. But if it is a major CHDs like a TGA, or if it is like a Fontan univentricular physiology, no, it's a big no for to do the retrosternal pull-up. It's a big no. So
Great.
first option, don't go for it. If you have no option, go for it. But for the further surgery, it's going to be easy if it is a minor CHDs, or if it is going to be a major anomaly, it's a real problem. Better to
Problem
avoid.
for you. Yeah. So I think we got the message from you, Dr. Saurav and Dr. Pradeep. So from my side, I think Dr. Vikesh wants to
Yeah.
ask a question. Dr. Vikesh, yes.
Firstly, I would like to congratulate Dr. Pradeep for detailing. I mean, you got less time, but all of your slides were very important and very useful to us. Thank you for your presentation. Rather than having two queries, like I would like to put up two curiosities in front of you. One is like, is there any pathway for a pediatric surgeon who is like sort of committed to become a pediatric cardiac surgeon in India or abroad, who can like, part away from pediatric surgery and go for pediatric cardiac surgery? One. And second curiosity is like, what about a lot of minimal access surgeries being done in adults nowadays in cardiac surgery as well? And in our field, like in pediatric surgery, 90% of the procedures, visceral procedures we do nowadays with minimal access surgery. So what is the role of minimal access surgery in pediatric cardiac surgery?
First, to answer your first question, sir, I'm in India. I'm sure there is no pathway. One has to go through the regular residency program, but abroad, I'm not sure, and it is less likely, I think, because the only pathway is to go through the again a cardiothoracic surgery residency program. That's the only pathway. And in case of second question, minimally invasive cardiac surgery is well established in adult patients. But in case of pediatrics, selective cases one can choose, because the main problem in the minimally invasive cardiac surgeries, we go for a peripheral cannulation. So in like a femoral artery or a femoral vein or even internal jugular vein is accessed for the vena cava cannulae and arterial cannulae. Instead of putting in ascending aorta, we put in the peripheral arteries for perfusion. So in adults, the arterial size and venous size is going to be big, so that it's easy for us to cannulate. In pediatric patient, it's going to be like too small for us to cannulate. So it's a bit difficult, but still it is getting established nowadays. What we do is we do a small thoracotomy, and for easy repairs like ASDs and VSDs, and in a selected tetralogy patients, we go for a mini thoracotomy and do it all the central cannulation through that mini thoracotomy only. It's a bit difficult, but yes, nowadays it's getting established. So hopefully it should be like be well established over time with the advent of newer cannulae. Basically, ours is gadget dependent surgery. So the better the gadget, it's easy for us to go through a small incision.
Thank you. Thank you for your answer.
Thank you, sir.
Over to you.
Yeah, Dr. Vikesh sir. Okay, so with that, I think before I hand over the proceedings to Dr. Advait, I thank Professor Saurabh Gupta, Dr. Pradeep Ramakrishna for sharing their knowledge and experience in this forum. Over to you, Dr. Advait.
Thank you. Thanks a lot, Dr. Anjan and Dr. Vikesh sir. And I must thank both the speakers, Dr. Saurabh and Dr. Pradeep, for very explicit and crisp presentations. I now request one of our EC members, Dr. Avinash Jadhav, to present vote of thanks. Dr. Avinash, over to you.
Good evening, seniors and friends. And on the behalf of Pediatric Society for Pediatric Thoracic Surgery, I would like to thank the moderators of the evening, Dr. Vikesh Agrawal sir and Dr. Anjan Dua sir, for a very definitive role they have played in keeping this session quite interactive and interesting. And most of all, I'd like to thank our esteemed speakers, Dr. Saurabh Gupta sir and Dr. Pradeep sir, for their crisp and enlightening presentations. And they made a special effort to keep it interesting for us pediatric surgeons. And that's why they deserve a very special thanks. Thank you, sir. I'd like to thank Dr. Biswas sir, who has been kind enough to join our webinar and has always been a guiding force. Again, I'd like to thank Dr. Vikesh Agrawal sir, IPS Secretary, for allowing us to use the Zoom platform. And he was kind enough to moderate the session as well and sparing us the evening with us. I'd like to thank our chairman, Dr. Manoj Joshi sir, for all his guidance and ideas that he has been giving us to keep this society sessions very interesting for everyone. Most of all, I'd like to thank all my colleagues, EC members, who have been there all the time to support the sessions and to support the activities. And most importantly, all the participants who were there for the evening. And I hope this session had helped all of us a lot, I'm very sure. And in this, so good evening, good night, everyone, and thank you for your time and patience. Thank you.
Thank you.
Thank you. Thank you so much, sir.
Thank you.
Thank you.
Thank you, everyone.
Dr. Pradeep and